Hello, everyone, and welcome to this year's MyIBD Learning virtual program, Exploring Options in IBD Surgery. My name is Laura Bryan. I am an IBD patient. I am on the Patient Advisory Task Force. I'm a patient with ulcerative colitis, and I did not heed my doctor's advice to take advantage of opportunities such as this and resources to find out about surgical options. And I had an emergency colectomy in 2020. So I highly recommend taking advantage of resources such as our presentation today, and we're excited to get started. As we know, as IBD patients, it is possible that we may opt for or require surgery at some point in our IBD journey. Tonight, we'll have the opportunity to learn more about IBD surgical options so that we are prepared to have informed discussions with our healthcare teams and loved ones. And I cannot stress the importance of this enough. So we're excited to get started. In order to make the program more interactive and to find out how much you've learned tonight, we'll be asking 2 questions via poll on our screen now. Let's start with tonight's first question. Are you more likely to have surgery if you have Crohn's disease or ulcerative colitis? Let us know what you think and pick the answer you think is correct. Directly underneath, you'll find our second question. Is this statement true or false? If I need a stoma ostomy bag, then my medical treatment and surgery was a failure. Select true or false. I'll give everyone a few seconds to make their selections. At the end of Dr. Poylin's presentation, we'll ask these questions again to see how much the group has learned. Let's see. Thank you for your participation. It looks like most people selected Crohn's disease for if you are more likely to have surgery with either Crohn's or ulcerative colitis. And then for if you need a stoma ostomy bag, then my medical treatment and surgery was a failure. And most folks have selected false. So thank you for your participation. And on behalf of the Crohn's and Colitis Foundation, we thank you all for joining. I'm going to get rolling here. The information shared is meant to be for educational purposes only and should not replace any advice or guidance provided from your own healthcare professionals. The program will be recorded and posted on the MyIBD Learning website, www.crohnscolitisfoundation.org/MyIBD Learning, and everyone who registered for the program will receive the link with the recording next week. We want this to be as interactive as engaging as possible. So we encourage you to submit your questions through the Q&A box, which can be found at the lower part of your screen. Following our expert discussion, I will moderate a Q&A session with all of our panelists and will address as many questions as we can at that time. Okay, tonight's speaker, our featured presenter tonight is Dr. Vitaly Poylin. Dr. Poylin is the director of section and colon and rectal surgery at Northwestern Medicine. He finished his surgical training at Beth Israel Deaconess Medical Center in Boston and colorectal training at University of Minnesota. His clinical practice concentrates on inflammatory bowel disease and colorectal cancer, mainly in minimally invasive approaches. He leads and is part of a number of local and national research trials. He is involved in patient advocacy and training of medical students, residents, and advanced care providers. Our Q&A expert this evening. We understand the importance of your questions and want to ensure as many of your questions are answered as possible. Tonight, we have the honor of having Dr. Daniel Chu monitoring the Q&A box. Dr. Daniel Chu is a division director of the Division of Gastrointestinal Surgery at the University of Alabama at Birmingham. He finished his general surgery residency at Boston University Medical Center, where he served as administrative chief resident. After residency, Dr. Chu completed a fellowship in colon and rectal surgery at the Mayo Clinic. An acclaimed surgeon scientist, Dr. Chu's National Institute of Health funded laboratory focuses on identifying, understanding, and reducing health disparities in surgery, with particular attention into health literacy. If you have a question for Dr. Chu, please type it in the Q&A box. We will do our very best to answer as many questions as he can, keeping in mind he may not be able to address every question. Following Dr. Poylan's presentation, Dr. Chu will join him for a live Q&A session. For our disclosures this evening, we do not have any disclosures.
All right.
Now let's get started with tonight's conversation on exploring IBD surgery. This time, I'd like to welcome our featured presenter, Dr. Vitaly Poylan.
All right, Laura, thank you very much for this introduction, and welcome everybody. I'm very happy to be here. As Laura mentioned, my name is Vitaly Poylan. I'm a colorectal surgeon in Northwestern in Chicago. And my goals for today is to talk about indications for surgery for inflammatory bowel disease, go into some of the details with differences between surgery and procedures needed for ulcerative colitis versus Crohn's disease, and then talk a little bit about perioperative issues and expectations. Now, the care for patients with inflammatory bowel disease is truly a multidisciplinary approach. As much of advances as we made, Crohn's is still a lifelong disease that we cannot cure. Ulcerative colitis, I can cure, but it does come with the consequences. So despite all the advances, despite how well we're doing now compared to 5, 10, 20 years ago, it is still a team sport. Patients who have Crohn's disease still have about 60 to 65% chance of needing to have surgery in their lifetime. Patients who have ulcerative colitis need about 20 to 25% of the time will still need to have surgery. Now, we can move on to the next slide. What I really want to concentrate today about is kind of what Laura mentioned in the beginning, because the reality is if somebody's really sick, if their colon and the intestines are really sick, although you always have a choice, your choices are very limited. You may be in a situation, look, we have to do something or else. And in that situation, the choices of what I can do, what Dr. Chu can do as surgeons are very limited. So what I want to concentrate on is more when you have time to think about it and decide and discuss your options and share it with the rest of the team and the family. Now, when we talk about the surgery, mainly kind of what we need to do in your belly for IBD surgery, it kind of depends on the disease. So ulcerative colitis affects colon. Crohn's disease can affect colon, but can also affect other things, your small bowel, the anorectal area, in some combination of above. So kind of what options we have, they're kind of limited and then guided by what type of a disease you actually have. So currently, what are the indications to have a conversation with me or consider surgery? The most straightforward one is failure of medicine. Practically speaking, no matter what we throw at you, it just doesn't work. With some nuances, and the questions what I want to know when I talk to my GI colleagues, well, do we have any options? Is this something reasonably new and we have all arsenal of all these medications that we can try, or we already ran through pretty much everything and nothing is really working? Sometimes medication works, but we don't really want to give you that medication for too long, with steroids being a very good example, because steroids will make almost everybody feel better, at least temporarily. But after a while, steroids will mess with every single system in your body. So if we can't get you off steroids, if we can wean you off, that's an indication to consider surgery. As a lot of you know, after a while, especially with ulcerative colitis, people have increased risk for cancer. And if we are starting to see the early signs of kind of this precancerous stuff popping up throughout your colon, you need to have surgery, because even though we do really well endoscopically in finding some of the polyps, if a colon starts to go, it starts to go. With Crohn's disease, after a while, all of that inflammation develops into a scar, and it essentially becomes a mechanical problem. And as it is right now, we don't have any good permanent solutions to the mechanical problem. It does require surgery. And then in some cases, it's a personal preference. Whatever people tired of kind of a situation they're in, or medications, or everything else. And as everything in, if you don't, next slide, please. As everything in medicine and surgery, it's a balance, right? We want benefits to outweigh the risks, right? So on the surgical side, it is surgery. If we can go to the next, and I'm not going to try to kind of minimize what it is. It's surgery. We're going to cut things. It's very anxiety provoking, right? There are risks associated with surgery. It can affect your life. It can affect your work life. So, but we have to balance it in this decision making. Do we have any other options? If we know that the surgery is coming, if we wait for too long, is your outcome going to be worse compared to if we do it in a timely fashion? Are your options going to be diminished? In things like Crohn's disease, when it is chronic, are we going to burn the bridges and not going to be able to use some of these medications? And this is what we kind of constantly doing as a team, that includes you, obviously. What is that what we can do? Now, if as part of this balance, again, surgery always is going to have risks. And in trying to figure out, is it time to consider surgery? Where these risks and benefits lie, we have to start considering that what can actually affect the complications around the time of surgery, because it advises us what options we have and how we're going to approach it. So steroids, what I already mentioned, they don't just mess with everything in your body, but they also significantly increase the risk of surgical complications, especially large doses of steroids for a long period of time. Some of the biologics like Remicade and Humira do as well. Some of the new ones, some of them actually quite safe, like vedolizumab and Stelara seem to be quite safe. The other ones, we just don't know, because they haven't been in the circulation for long enough time for us to know. Nutrition is very important. If people are losing weight, if people albumin is a measure of protein, and that's kind of a measure of your nutritional status. If people are not doing well, it increases rates of all kinds of complications. People who have perforations, people who have active infection, that's a significant risk factor around the time of surgery. And obviously, if there are other considerations, malignancy, any other diseases that needed to be treated, that we have to balance again with what we need to do. Now, let's switch gears a little bit and start talking about specific diseases. As you know, ulcerative colitis is a disease that kind of starts at your bottom, makes its way out to the small bowel, and then stops. So people who need surgery for ulcerative colitis, practically speaking, if they need to have surgery, if colon and rectum has to go. And then fundamentally, you have a couple of options. We have small bowel, and we have the anus where your sphincter muscle is. And we can either, and it's called, if we remove it all, it's called total proctocolectomy or proctocolectomy. We can either sew things shut down at the bottom and give people a permanent stoma. We can put things back together, and it's called a pouch or J-pouch. In some cases, we can make a continent ileostomy, and very rarely, and it requires additional discussions, we would kind of compromise and either remove part of a colon or most of a colon, but not all of it. Now, going through some of these options in a little bit more details. So if you can go to the next slide. So if we take everything out and give people a permanent stoma, once I sew things shut down at the bottom, There is no going back. However, everything is out. There is no connection that we have to worry about. There is no risk of cancer. We don't really need to monitor you, but there is no going back. It is a good option for oftentimes older patients, somebody who has trouble getting to the bathroom because of bad joints or what have you. You know, if we give them, if we reconnect them, it oftentimes they mechanically everything may be okay, but they are not very happy. People who have a lot of medical problems, but also important one is patient's wishes. The youngest patient I have who essentially wanted everything out was 26 at the time, and essentially what she said was, look, if I'm going to be done with this disease, I am done. I'm never thinking about anything ever again. Done, which is perfectly fine. Now, some people, if you go to the next slide, we can't put things back together. Again, fundamentally, your colon is responsible for absorbing water. Rectum is your reservoir. You need to go to a bathroom. Right now is not a good time. I'll go later. So when we take out the colon, the stool becomes much more loose. We can make a reservoir. It's called a J pouch, but it is a guarantee that things are going to be different. The main advantage is that we put things back together, and ultimately people go to the bathroom the way they do in the beginning. But it is very different. We expect people to have at least 6 to 7 bowel movements a day and perhaps 1 to 2 at night. We do have to watch you. We have to look inside the pouch. We have to monitor you. There is a reasonable chance up to 20% of some sort of reintervention that needs to be done. And sometimes as we make that connection and hook it up, that connection gets a little tight and we have to open it up. Pretty simple. But sometimes it needs to be much more involved. Age is not really a limitation in this. We now do it for people of all ages, but it is very important to have a detailed discussion of what it actually means. What are the expectations? And this is where the expertise does come into play, because the more you do this, you know, because we are creating the anatomy that wasn't intended to be there, right? So it has to be watched, it has to be done. And the more experience folks have, the better the outcomes are going to be. Next. And then in some cases, and I'm not going to spend too much time there, we can take everything out and create a reservoir inside. And if you can see the picture kind of on your right there, essentially you have a little bit of an opening, nothing comes out, and people use the catheter to empty out. So it's not something like in a regular ileostomy and things kind of come out over time. It's a good option for selected patients. These are very, very finicky. The rate of reintervention, the need to do more surgery is very significant. For a couple of places that will do that, but for most part, between the ileostomy and doing well with a pouch, we don't often have to do anything like this. Next. Now, another thing that we always discuss when we talk about it in how do we do this? This is not a surgery that we kind of do one in and done. We practically do it in what's called a 2-stage. We take out the colon, we make a rectum, we make a reservoir, we hook it up, and we give people a temporary stoma. I'll come back to it in a second. Or we do it in 3 stages. When we take out the colon, then come back, make a pouch, and then take down the stoma. And the reason for that, and the reason you see ileostomy, and that's a type of a small bowel stoma that we make for this procedure, is because whenever we do surgery, we're always going to be risk, and we'll come back to it in a minute, but one of the biggest things we worry about is called a leak. Whenever we cut the bowel and put it together, there is always a chance that things may not heal. And the chances of it are generally quite low, unless you have inflammatory bowel disease, unless you're on some of these medications, unless we make a pouch and make a connection down in the pelvis, and then the risk can go up and up and up. And then if that happens, it doesn't just affect your immediate recovery. It actually affects function of this pouch for years to come, if not forever. And all of this is about the function. So on one hand, the 2 stages, less surgery, fewer operations, less time under anesthesia, but this is really a procedure for somebody who walks into the office and say, maybe something funny in my colon. I'm not perfectly happy, but I am okay. I'm busy with spring. I want to do something in the summer. Nutritionally, I'm doing great. Let's just plan something for a future and go. Perfect. The free stage is for folks who are kind of getting sick. And the main reason for kind of splitting things out is because the main part of this whole thing is actually taking out the rectum and making that pouch. And I'll tell my patients, look, it actually takes me less time to take out 6 feet of your colon than take out half a foot of your rectum and make a pouch. And that's the more important part. So folks who are sick on a lot of medications that can affect recovery, if they're nutritionally not doing well, the first step is just to get them better. We take out the colon, we get them better, get them off medication, and then we come back when people are in a much better shape and we can do a better operation with fewer chances of recovery, and then finally get rid of the stoma. Okay. Now, switching gears a little bit, and we'll combine things at the end. If we're talking about Crohn's disease, unlike ulcerative colitis, which I can cure, right? If I take out the colon and rectum, it is gone. But again, it is surgery. It does have consequences. The Crohn's disease is a lifelong thing. We know we can't get rid of it. So the goal of surgery is to make people better and to make kind of medication work better. So the best case scenario is when we actually remove the portion of our intestine. The best overall outcome long-term is when I finish the surgery and everything else looks like you don't have a disease. We know you have it, but everything looks perfectly normal. This is a kind of a first time around, plenty of bowel left. We know we're not going to really be affecting things. However, Crohn's disease by itself has a higher chance of complications and leak that I mentioned, especially if it's a disease with an active infection in the fistulas that connect a couple of different parts of intestinal tract. If somebody with, remember that stricture that I mentioned, if they've been blocked off and the intestine balloons up and dilates, that can be an issue. And the worry is that people who have a disease that kind of keeps on coming back, that eventually we're going to start running out of the gut. And whatever it's going to be, starting with looser bowel movements to then issues with hydration. And what we all worry about is if it's going to be an issue with actually nutrition. So in that case, we have an alternative. And that's a stricturoplasty. So essentially what we do, if you look at the picture at the bottom, that area of a narrowing, we open it up and we close it in a different way that things can keep on going through without needing to remove the bowel. The advantages, we don't really remove anything. The disadvantage is that we don't remove anything. So there's still disease in there and everything else. So and there's still going to be the risks of leaks and everything else. So but those are the options that we'll kind of entertain based on how how things are and how people are and how active their disease is, because for Crohn's especially, it has one name, but it's really different from person to person. Okay. Now, we can probably, if you don't mind, just start the video and just go somewhere towards the middle, and I'll just talk a little bit as it kind of, somewhere in there is fine, like as it goes from about. So when people will talk to you about, there are different approaches, right? This surgery, we can do open, we can do laparoscopic, now we can do robotic, we can do assisted. But if the way to think about it, it's all about, those are tools, those are instruments. The goal is to do the surgery, do the right surgery, and do it well. And yes, if it can be done laparoscopically or robotically with smaller incisions, great. The recovery is going to be faster. The pain is going to be less. But we can't compromise somebody's health and well-being for a couple of inches of incision. It is just not worth it. So folk, me and my me and my partners and other colorectal surgeons, we have no hesitation to making a bigger incision if that's what it takes to get somebody through the surgery faster and in a better shape. Okay, this is just the reporting of doing the surgery anastomosis robotically for Crohn's disease. But again, think about it as a tool. But we concentrate on what is the goal is and trying to figure out what the best tool for that job. Okay, we can probably stop and move on for purposes of saving time. Now, the questions that I know people, even if I don't ask, I know everybody's thinking about, well, what about the bag? And the way to think about it is really there are two things couple of things that I would say. So first of all, when you do surgery, you have to have plan A, plan B, plan C, and everything else. And remember what the ultimate goal is. We need to get you through this stuff into a kind of a normal or new normal or whatever it is. And it does include avoiding complications. We need to do it to preserve the bowel. And what the stoma does in a lot of people, provides us that bridge. For example, remember what I talked about when the pouch and the leaks and things like that? When we make that stoma, in a lot of instances, even if there is a little bit of a leak, more often than not, we wouldn't even know. Because what the stoma does, it allows all of that healing to happen. And it's always better to have two scheduled procedures, get through them in one piece, when one with complications probably end up in the same place, but in a much worse shape. And that's what oftentimes for the stoma can kind of provide for us. Or in Crohn's disease, when people have it narrowing and the bowel is really dilated and not in a good shape, you know what? Instead of doing that, risking the leak and infections and probably end up losing more bowel at the end, we're going to do that. We're going to cool things off. We're going to come back and deal with it down the line when the person, actually, we can go back in 1 second. Yeah. And then now back to the stoma slide. So, and another thing is what I can tell you is that in some people, it is a good end solution. And it's actually, there are two things that are very common. So first of all, oftentimes in people who will give a temporary stoma, and then we will come back and then we'll get rid of it. And they'll say, you know what? I'm okay, but it's not going to be there anymore, but it wasn't bad. It is also very common, especially when people come in sick, and oftentimes they've been sick for quite a long time before we get to surgery. I will tell them, it's like, you know what? You're actually doing well. If you want to start planning for the next step, we can do that. And it is very common for people to say, you know what? I'm actually feeling well. I haven't felt well in a very long time. Yes, I want to do something. I want to actually go back and live my life, catch up to my work, do other things, and then I'll come back and deal with it later. Okay? And it's also not uncommon for people who, when we start this journey, let's say in ulcerative colitis, then they'll say, oh, I definitely want to be reconnected. And then we'll do the first step, and they'll come back and say, you know what? This is good. Let's just, we'll get rid of a rectum at some point. My life is back. I can travel. I can do anything I want. So it is really not kind of an end all. We do have options around it. We do have a lot of support that we provide around it. And it's really, it's really something that is not necessarily like to be as worried about. All right. Now, talking about some of the other perioperative issues that we talk to folks about. It is surgery. Again, I'm not going to minimize what it actually is. Infections, whatever it's a wound infection or whatever it's infection inside the belly. And some of it, again, nature of a disease, it's medications that we use for this, bleeding. It's very rare, but it can happen. Hernias. Whenever we cut the belly and put things back together, it never reaches the original strength. Sometimes it happens. Oftentimes we don't need to do much about it. People who do have a stoma can have some issues. between it's kind of coming out. And usually it's reasonably straightforward, kind of a leakage and irritation. We can deal with it. But again, everything, there is no free lunch in medicine. Everything has potential consequences. If you have surgery for inflammatory bowel disease, more likely than not, you will be getting some blood thinners, because we know between inflammation and surgery, there is definitely a high risk for blood clots. And if it happens, we need to treat people for many months and may delay our treatments. And now a very important thing, and we'll oftentimes will spend much more time talking about that what it actually means functionally. What does it mean for, if it's ulcerative colitis in the pouch, going to a bathroom, as we discussed? What does it mean for hydration, reintervention? And now the important thing, especially in younger folks, whenever we have to go into the pelvis for either ulcerative colitis or Crohn's disease, is the fertility issues. Especially with minimally invasive surgery now, the chances of having issues with fertility is lower, but it's still both men and women may have some issues with that. For men, it may have to do with erection and things like that. And it's not on, we oftentimes will talk about folks getting like a sperm banking or something like that beforehand, if they're really worried about it. Again, rarely an issue in these situations. In women, has to do with scarring. Again, less likely with minimally invasive surgery, but something that worth discussing with your physicians, because it can affect how we approach things, timing, and everything else. Now, what is that what you can expect? And, obviously nobody want to be in a hospital. Nobody want to be there more than they have to be. So practically for people to go home, they obviously need to be medically doing okay, need to be eating, understanding that the appetite is not going to be great in the beginning. Everybody loses weight before it starts going back up. Things need to be coming through, whatever, having bowel movements or stoma needs to be working. Pain needs to be okay. And it's important to know that we're not looking for zero. We're looking, the zero will come with time as people recover. We're looking for folks to be comfortable enough to be able to eat, sleep, get out, move around. And that's what we're looking for in the beginning, and being able to move around and be somewhat active. Now, this is a short term, and in some people, it will happen in a day or two. The long-term recovery definitely takes longer. Even if we do everything with a very small incisions, it's still a big surgery on the inside. It takes good 6 to 8 weeks because people feel weak. They feel tired. It's expected that people are going to lose some weight. There are going to be some dietary limitations. The things are going to be different. People have to readjust. So it's very common, for example, we'll see folks in 2 weeks and they'll say, oh, I feel pretty good. And then we'll see them in 2 months and say, okay, well, now I'm really feeling good, because it does take time. And then in a lot of these folks, again, these are chronic conditions. We kind of get the folks for life, right? We have to look inside the pouch. We have to do the labs. We have to do the imaging. We, stay in touch. We kind of contact, and that's kind of a part of this whole, multidisciplinary care of this disease. And then this is a whole separate talk that is kind of it's a whole separate conversation, but I just want to mention some of the issues with the perianal disease. Now, perianal disease is actually second most common site of Crohn's disease after the end of a small bowel, right before it meets the colon. But it can happen in ulcerative colitis as kind of a true and unrelated. And that's why it's kind of paired together. So people can have ulcerative colitis and happen to have abscesses, fissures, and hemorrhoids because these are common, or it's a truly part of the actual disease. But there is a significant difference in how we approach it. So if somebody has an infection and have an abscess, we need to open it up. If somebody has the fistula and just happen to have Crohn's disease, we will treat it pretty aggressively. We will do surgical procedures to try to fix it, versus in Crohn's disease, usually we'll treat with medication, and we'll put cetons, the rubber bands, in there to try to kind of keep the infection under control. Antibiotics for Crohn's disease, it's a yes. For other conditions, it's usually a no. For folks who coming off the street or have ulcerative colitis, that all of these medications we use for ulcerative colitis, they don't work for hemorrhoids and abscesses, but they do work for irritation related to Crohn's disease. And then ultimately, there is going to be a minority, but a sizable minority of folks who have perianal Crohn's disease that no matter what we do, we just can't keep it under control. And in those cases, we'll actually consider giving people a stoma to actually just improve their quality of life and make sure that they can actually sit and kind of do things that they want to do. And on that, I think I'm going to stop my part here. So, except that, thank you for doing that. But in summary, surgery is really not a failure. Surgery is integral part of treatment of ulcerative colitis and Crohn's disease. And we work very closely in conjunction with our colleagues from GI. You know, in my division of GI surgery, I probably spend more time talking and kind of dealing and discussing patients with my IBD gastroenterologist when with bariatric surgeons in my own division. And it's important because we just talked about a lot. There are a lot of steps, there are stomas, there are multiple surgeries and all of these things, but it is important to keep the ultimate goal in life. What is that we're trying to do? We're trying to, even if we add an additional step, we take longer, we do some things that nobody wants to talk about, is because we ultimately want everybody to have a good outcome and improve their quality of life. Thank you.
Absolutely. Dr. Poylan, that was amazingly helpful. I wish I had known you 5 years ago. I think it's very important to know all the different surgical options and the long-term and short-term effects of those, and that it's not a one-size-fits-all option. So I think it's very important. So we're going to be gathering some questions from the Q&A box. We'd like to resubmit the 2 questions that we posed initially to see how much everyone has learned. And just to refresh your memory, are you more likely to have surgery if you have Crohn's disease or ulcerative colitis? Please make your choice. And then after we've heard the presentation, if you've changed your answer to if I need a stoma or ostomy bag, my medical treatment and surgery was a failure. And that's a true or false question. So we'll wait just a second there. All right, and let's see, this is great. So the correct answer for are you more likely to have surgery if you have Crohn's or ulcerative colitis is Crohn's disease, and that's the answer everyone selected. And for question number 2, if I need a stoma or ostomy bag, then my medical treatment surgery was a failure. The correct answer is false. It looks like almost everyone has selected false, so that's fantastic. So having a stoma or ostomy does not mean your medical surgery was a failure. Actually, I think that was the most common things ever were for me, was having that ileostomy. So let's see here. So we're going to take some direct questions from the audience. And I'd like to welcome Dr. Dan Chu on camera if he's with us. So I know he had a
Hey everyone.
Hello, Dr. Chu. Welcome. Thank you. And he's been answering questions for us throughout the chat, and we're going to direct a few of the questions to our expert presenters. And if you have a question for Dr. Poylan or Dr. Chu, please type it in the Q&A box, and that's in the lower part of your screen. And I'm going to go ahead and jump in because we've got a couple of questions that have been submitted. And our first question for Dr. Poylan is, can you discuss the difference between an S pouch and a J pouch, and are there any differences in how the pouch is empty, or does one have more likelihood to fail than the other?
That's a great question. So there are actually kind of a 3 common configuration of pouch. The most common one used is called a J pouch. It's now close to 40 years old, and you have a lot of experience with. There's an S pouch, and it kind of looks like an S, and there's actually a W pouch that's only done in a couple of places in the world. And there's been early on a lot of studies comparing them, and a J pouch uses the minimal amount of bowel, which remember will how much bowel we use up, it ends up affecting your function, going to a bathroom and things like that. What the S pouch it does is actually provides extra length. So in the situations where that pouch just does not reach, and we're trying to get it down and we can't get it down, so the S pouch gives you an opportunity to essentially get close to an extra inch. The downside of that, it does use more bowel, and that little, it's because it's kind of looks like an S, and it's the end of that kind of an S, little snout what we connect. It's actually can elongate over time and cause some issues with obstruction. So generally speaking, when people go for a surgery for a pouch, the intent almost always in the beginning is to do the J pouch, just because it looks like a letter J for the reasons I discussed. However, S pouch is my backup. Okay, so if I can reach, if I need a little extra length, that's when we're going to do this.
Got it. Fantastic. Let's see. We've got a second question we'll jump into. We can start with Dr. Chu and welcome additional thoughts from Dr. Poylan. How large is the risk of infection with stoma, given that it's an opening into the body?
Yeah, great question. Just about to answer it. So the risk is actually not what you think it is. When you have an ostomy or bag open to the skin, we actually don't see much infection in that area. Now, it can happen, don't get me wrong, with stoma care that isn't done correctly, such as skin care, or if the stoma separates from the skin and we don't kind of care for it properly, then that can get infected, don't get me wrong. But generally speaking, with an ostomy, even though there's waste coming out, it's pretty remarkable. The infection rates are exceedingly low.
Yeah, I like to think about it this. So, your skin is a great barrier for infection, right? And things will come out, and it's the most common issue with a stoma is irritation. As Dr. Chu said, if things are not fitting properly or something like that, the area will get irritated, but amazingly enough, it doesn't get infected. Now, way of thinking about it, as long as things are flowing, and that's actually true for anorectal disease and fistula, as long as things are moving, people don't get infections. So irritation, yes. Infection, not so much.
Fantastic. I think too, if I may add, they have actually, it seems like there's a lot of ostomy specialty nurses and teams and resources that folks have. And if you ask questions and learn how to keep things clean and how frequently to change the bag, then it that can normally go without issues. So using those resources, I think is important. Let's see, what are some possible complications of total proctolectomy and permanent ileostomy in Crohn's disease?
It's a good question. So first of all, it is entirely possible to live without the colon. Okay, we do this, for ulcerative colitis, for Crohn's disease, sometimes for other indication. You don't need the colon to survive. Okay, now remember when I mentioned that the role of a colon is to absorb water and some of the vitamins, right? Like vitamin K and a couple of other things. So practically, it almost doesn't matter what your indication for taking it out. The things what we're going to worry about, at least in the beginning, is going to be dehydration, right? Because more stuff is coming out, and the body has to readjust, and the colon doesn't absorb it. Irritation around the stoma. The biggest issue with Crohn's disease, even though there are folks who have it isolated to just, let's say, colon, is that this is something that can happen in other places. So what we worry about is that, well, your colon was really diseased and we had to get it out. And now we're going to keep on in ulcerative colitis, we're done. That's it. In Crohn's, we are going to keep on watching and oftentimes keeping people on medication, because if it starts happening somewhere else, then we're going back to surgery and things like that. But the main issue is really kind of a dehydration and kind of adjusting to just having a stoma. And I want to kind of a second what Laura said, where the wound, we're called technically wound and stoma nurses. But like, for example, we have, and I'm sure Dr. Chu as well, we have in my division, so right now we're 4 colorectal surgeons, and we have 2 stoma nurses that are actually, in one is an outpatient who is going to be switching full-time, who are dedicated specifically to essentially just stomas. They are amazing. They, oftentimes for folks, they're probably a much better resource than I am. And they do a great job, and they they help me a lot. They help our patients a lot, and it's general recommendation from Crohn's and Colitis Foundation, from all the professional societies that the folks who kind of consider it to actually meet with them before, have conversation, and have access to that resource.
Absolutely, absolutely. Yeah, I think in a year, I had the ileostomy twice and a takedown surgery twice in my situation. And I had one leakage situation because of the training that I received and having those resources. So I think that's very important. Let's see. We definitely want to thank Dr. Poylan and Dr. Chu for this session. And one follow-up question: what are the best things you think patients can do to set themselves up for success while waiting for their ileostomy reversal surgery?
That's a great question. So I'm going to start. So surgery is always going to knock a wind out of you, right? No matter how small the incisions or everything else. So the best thing one can do is be in the best shape to be, because if you're here, you're going to be here. But if you're here, you're going to be down below. So being physically active, being nutritionally in a good shape, so those are the things that kind of very practical and anybody can do. Okay. And then another thing is really to talk to your team, okay, about what does it actually mean? What does the function mean? What does it mean for me? What does it mean for my medications? What does it mean for, in most of the places, or through, Crohn's and Colitis Foundation, you can probably reach out to our patients and get their perspective. So think about it, it's like, Boy Scouts, be prepared. The more prepared you are from your body, what kind of knowledge you are, the better you're going to be when going through a process and on the other side.
Yeah, and I would add that it's very stepwise, the things that need to be done oftentimes to prepare for surgery, especially for an ileostomy reversal. There are certain tests that sometimes need to be done before reversing. There was a question earlier about, what are the things you need to worry about for reversal? And I think one is just the anatomy, is it technically possible to reverse? And the other is the indication, like, are you ready? Is it correct that we should reverse? And working with your surgeon and your team sets you up for that. And I think knowing all those steps, like Dr. Poylan had said, is really critical, because it helps you as a patient also engage with each of those steps. Even like before you enter the hospital, right? And then even when you're in the hospital, engaging with all those steps that you need to really ensure that you have the best chance for a really great recovery is just critically important.
Absolutely, absolutely. If I might add again, I think the diet, what you can eat, when you have the ileostomy, or before surgery, after surgery, I think that involving those dietitian resources is really important, because you can, you mentioned that you can actually have too much liquid in the bag, or actually have diarrhea when you have the bag, and those are things that you might not necessarily know. Another interesting question. Let's start with Dr. Chu. If someone with Crohn's has to have a resection for an anastomotic stricture? Does the entire anastomosis get removed and a new one is created?
Yeah, great question. So it sort of depends, I would say, on the anastomosis. So this is really a mechanical problem if you think about it. If you think about the intestines as a long pipe, and you have a previous connection that was made, and that connection now is narrow, it is causing symptoms, usually obstruction sometimes. And so your options would be to go in. One option is to go in and remove that old connection and then to redo it. And then that would be sort of a very common way of addressing strictures. Another way that can be done sometimes is if it's a small stricture, is you can actually open it up and just make it wider. That's probably less common in this type of situation, but can be done with a strictural plasty. It also depends on where the stricture is. And what I mean by that is if it's a really like low connection, like your colon to your rectum, and there's a stricture there, those can be really challenging to take care of because there might not be enough new target landing pad for you to make a connection to. And so in those cases, you might consider using endoscopic ways to dilate a stricture if it's really kind of low and narrow and risk losing, ability to make a connection. So I think those are, and hopefully I answered some of your questions about that.
Excellent answer. Let's see.
Oh, and sorry, I saw a second
Look,
part
if
to
you
that
need a
question. Oh, sorry, I saw a second part.
Okay, got it. Okay, great. Thanks.
Is there a
Great.
type of anastomotic configuration? Yeah, so that's a huge question. Great question. Still a lot of research that's out there. So there was a question earlier about the Crohn-OS anastomosis. Certainly a lot of good data supporting that connection as decreasing chances of recurrence. People have looked at hand sewn versus stapling techniques when you talk about connecting bowel and Crohn's disease, with some evidence suggesting that stapling might be a little bit better, is what I've seen more recently. So there is, I think, some configurations. No one, I would say, no one configuration of that is like the absolute like gold standard. So and I'll be curious to see what Dr. Poylan has to add to that.
Yeah. No, it's a great question. It's actually kind of from academic standpoint, it makes some of his meetings and discussion very heated and exciting because it's actually, on one hand, there's a configuration of anastomosis, right? There's in the Crohn-OS. So I do Crohn-OS more often than not because the current data does suggest that it may decrease chances of recurrence, need for medications, and things like that. However, this data is reasonably early, right? What he mentioned, the data between like stapling and hand sewn, we now have data going decades. For Crohn-OS, we don't yet, right? So we have all of these studies ongoing. At the same time, there are studies looking at how much mesentery, this fatty stuff with around the colon is taken out and how much that actually affects it. And then it's, I totally agree. There is no kind of one way. And we have to, in a lot of ways, like, do strictureplasty, it's the way I'm thinking about it, none of these things you can take in isolation. It's about the whole totality of a disease and then specific patient. Because, again, think about Crohn's disease. Again, one name, but so different from person to person, right? So in this situation, this may be a better option. And we're just starting to scratch the surface on trying to tease out a little bit, well, maybe for you and your subtype of a disease, this may be better, or this medication may be better, but we are very early in the process.
Excellent information. Let's see if we have any additional questions. I know we're probably getting close on time. Final question, is diarrhea normal after surgeries, for example, after a resection, or how do you know if it is a manifestation of active disease?
That's a great question. So I can tell you for pretty much any type of resection, whatever it's for inflammatory bowel disease and an extent, sometimes we can tell. Again, we take out all the colon, it's going to be loose, right? But pretty much any kind of a bowel resection we do, at least in the beginning, we expect some bowel movements to be looser, we expect them to be more frequent, and we expect them to be somewhat irregular. Now, where it's going to fall over time, and when I say over time, in some situations, it can take many months because this is functional. The body needs to readjust. Where things are going to fall, they may fall to a new normal. And it may have nothing to do with inflammation. It's just generally speaking. So, in some folks, it's going to be, I had a lot right after, and now I'm having, 2 bowel movements a day. Yes, it's different, but no, it doesn't bother me. Versus in some, that's why we have all this conversation. Yeah, it will be different. So you have to think about it, what it means for your life, work, and everything else.
Absolutely. Absolutely. It does seem like there are certain things that the pouch doesn't like sugar and things like that, or, and you mentioned hydration and even some medications, that can help with that. But, always important to ask your medical team if you're not sure if something's going on after surgery.
Exactly. And we are there. And by the way, a lot of this stuff is like functional and kind of guiding people through that. If you're traveling, so we can talk on the phone. We'll do it now by, through our medical record system and everything else, because these are very routine. And as Laura mentioned, medication, we have a lot of medications that we can use and a lot of little tricks and things that will teach people between our stoma nurses and us and the dietitian and kind of what to do. It just, there are a lot of things that we can do and kind of work with people, and we do. It's part of this journey.
Yeah, I think that constant communication is really important. Having that instant message through your, your portals with your doctors these days is very, very, very helpful. So, let's see. Here's one more question. This might be the last one we have time for this evening. What are the effective treatments for chronic pouchitis?
That's a great question, and it's somewhat controversial. So fundamentally, pouchitis is inflammation of that pouch, right? And it's because we're making the small bowel to be a reservoir, and it was never intended to be a reservoir, right? So we're making it do something it's not intended to do. In most people, when it happens, and it can happen up to 40% of folks, it's a rare occurrence. We'll say, I've been doing fine, and all of a sudden I have increased frequency. I see a little bit of blood. We'll put them on some antibiotics, and they'll be fine, and that's it. There are some patients, when it becomes chronic, and it always becomes a question, is that a technical issue? Is there Crohn's? Is there something else going on? So there are some people that will put on essentially chronic antibiotics, and it actually works for them in kind of trying to keep things under control. There is some okay and reasonable data that in certain situations, things like vedolizumab can actually be a good treatment for chronic pouchitis. But again, this is where it's a team sport, right? This is something that if I'm like start encountering this, and me and my IBD folks, we see people together all the time, and they'll kind of take over and oftentimes start treating it almost as if it was kind of ongoing inflammatory bowel disease.
Yes. I'm on the permanent antibiotics myself for chronic pouchitis, and it definitely is helpful and it's been important to have those conversations. And I think we're gonna run out of time pretty quickly, and things will kind of end abruptly. So I wanted to just thank you all for, I think this is an amazing discussion. I think we had gained a lot of insight and a lot of helpful information today. And I want to make sure that we'll go over where the resources are, but definitely appreciate your time. And on behalf of the Crohn's and Colitis Foundation, we encourage you to keep learning about IBD and to visit our helpful educational resources listed here. You can also watch previous webinars and expert conversations on Crohn's Colitis foundation.org/MyIBD Learning. And I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We appreciate the feedback. This helps us plan future programs, make sure we're giving you the information that you're looking for. We thank you all, Dr. Poylan and Dr. Chu. Your time has been amazingly helpful, and we appreciate that, and appreciate everyone's participation and all of your great questions. And hope you have a great rest of the night. I think we're gonna wrap up with no notice pretty quickly. So I just want to thank you again for joining us.
And thank you, Laura, for moderating.
Thank you, my
Laura.
pleasure.
Thank you, everyone on the
Thank
call.
you. Thank you, doctors, for being here.